So in this last talk, I'm going to just look into the future a little bit about where I think paediatric anaesthesia might be heading. So, and I want to look at, some of these things have been touched on by the last two speakers, but I want to touch at some of the things that we don't worry about, very much like Xavier was talking about. We bang them on, we don't know that they come from the ICU and they've been on some sort of permissive hypercapnia or a high PEEP strategy because that's been worked out as best practice. These things have consequences, and I think there's a real call to arms in paediatric anaesthesia to up their game, to recognise that there are unforeseen consequences of what we do. So to sort of start by that, I think this is the underlying problem with our philosophy. So we breathe a sigh of relief when these patients get out of the operating room. They take something that's really sick, we keep it alive, we put it back on ICU, we put it back on the ward, and we think we've done a really, really good job. The cardiac surgeons breathe their sigh of relief at 30 days because that's when the mortality figures change, because then it's not their problem, it's somebody else's problem. But the neonatologists are well ahead of the game. They have been involved in long-term follow-up studies now for many years, where 2 years and 5 years are their outcome points. We need to latch onto that, and that's basically the talk, is I think we need to start latching on into not what we do in the operating room, but the fine-tuning that we need to attempt to up our game so that we look at this. There is great evidence that the neonatologists have made a difference. Maybe not so much in the 22, 23 week gestation babies, but in the 24 and beyond, they've made massive differences, both by the Epicure studies and the Scandinavian studies. They've shown improvement in their developmental scores from Bayley scoring and other scoring systems of neurodevelopment, reduction in cerebral palsy, and not just increased surviving, but long-term survival with good quality is where they're at. And that essentially, this is just briefly to demonstrate that. These are the two probably most known studies, and they all show that actually no impairment, mild impairment, is gradually improving. There is an age-related thing, so when you get down to this age group, these children have the more severe impairments. But the 26-weekers, if you look at the long-term study follow-ups, have got better. So I'm going to look at two areas that I'm going to concentrate on. There are lots of other things we could look at. We could look at analgesia and pain and long-term consequences of that. We could look at glucose and fluid strategies. We can look at apoptosis. But I think we'll just look at these two in the time we've got. So it's now over 30 years since this Robinson and Gregory paper showed that you could give analgesia, 10 mics per kilo, to a preterm baby having a ductus arteriosus repair, and show that you could control the blood pressure, and that would be beneficial in terms of the hemodynamics, and give these children some analgesia without the old idea that the analgesia was bad and it wasn't needed. And as a result of that, we all ran in one direction in the 80s. In the 80s, it was all about the more you give of analgesia, the better it is. So we went up to 100, 150 micrograms per kilogram of fentanyl. And even in the Boston studies, the big Boston study that was reported in the New England Journal, they went up to 500 mics per kg of fentanyl for a cardiac case. That is quite a big dose, I think, even by anybody's standards. And there was a few people in the desert who were saying, hang on a minute, we haven't done a dose response curve. Maybe that is quite a lot. And in fact, there is consequences. So this is an older study which we did where we looked at fentanyl doses. We only went to the modest 150 in cardiac patients and looked at blood pressure. Once you start getting into proper analgesia, there is a dose-dependent effect on blood pressure. So we have kind of moved away from that. And then it all comes down to outcome. And this is a study that mirrors a number of studies that have come out, which have shown that blood pressure is important in the highly fragile preterm neonates. So this was a study that looked at quite a large number of patients. They were randomly allocated to either get analgesia with morphine or a more liberal regimen with morphine. And they were looking at death and neurological injury in these patients. And morphine certainly reduced signs of pain if you gave more, but the result was worse outcomes in the morphine group. And that's kind of was a call to arms for people to re-evaluate what they were doing with analgesia in the preterm neonatal unit. And this seemed to be the determinant that people were worried about. It's not entirely fixed, but people are worried that it was the hypotension that was largely responsible for the increased neurological injury caused by the morphine, which pertains very much to what we do in our practice. We all know that blood pressure goes up with age, so neonates actually have quite a decent blood pressure. This is a term neonate, 75/45. Very few of our patients necessarily have that blood pressure when they're actually under anaesthesia. And we now have data which shows what the blood pressures are in all these different age groups. So this is a 37-week-old baby systolic blood pressure. This is a 26-week-old baby gestation blood pressure. And you can see how the blood pressure goes up normally on the first few days of life. But look at these numbers. These numbers are quite big. So this is systolic blood pressure, 26-week gestation baby, 55 systolic blood pressure. Again, higher than we normally think of. We don't worry about it, or we haven't worried about it very much up until now. But I think we probably should. And this is some data to show you how little we did worry about it. This is a very recent study, 2009. Very nice study, just a survey, very simple study, looking at talking to the SPA and the APA and asking them what you thought was a normal blood pressure and what you regarded as significant hypotension. And I think this paper is quite shocking in our responses. So, systolic blood pressure threshold mean for intraoperative hypotension. Neonates, 45. So that's a systolic of 45 in a term neonate, which we saw, 75 is what you are when you're awake. That is going down quite a bit in terms of blood pressure. And then again, we're asking here the changes from the baseline that you would think you might need to do something about. So a 20 to 30% decrease, 70% thought that was the threshold. There were people who thought you didn't need to actually intervene until the pressure decrease had been 40% decrease. I think that is a slight worry, because I think given the data that's out there in the last 10 years, we probably should be trying to get our blood pressures a bit more accurate. And then this is the gas study, which I think is really interesting, because this, again, my thanks to the gas consortium for letting me use this slide mercilessly, because I think it's such an important slide. So this is the gas study where we have awake, regional versus general anaesthesia in neonates, mean systolic blood pressure. And in the general group, there are systolic blood pressures, mean systolic blood pressures down in the 25s. Now we're looking for long-term neurological disability, comparing awake techniques with general techniques and talking about things like apoptosis and programmed cell death. Well, there may be some simpler answers here, that our blood pressures actually are lower than they ought to be. And we know from the data from the NeoPain study that actually low blood pressure may have significant consequences. And then there's the whole question of deconstructing blood pressure measurement. So this is, again, a recent study looking at comparing invasive arterial blood pressure measurement with non-invasive arterial measurement in the neonate. And they looked at 3 commercially available devices that use algorithms to mechanically give you a cuff and a value that gives you systolic, diastolic, and mean blood pressure. And there was up to 30% different measurements between the different devices. So the device you use will give a different answer in terms of what the blood pressure is. And if we're talking about fine-tuning our blood pressure measurement, and there's a 30% difference between one cuff and the other, then there's a worry. And these are intermittent measurements. I think we need to up our game on blood pressure measurement. For too long, we have relied on the thing that comes off the wall and say that's fine. If you go back to when we used Dopplers on the radial artery and we actually measured it by hand, I think we had better understanding of blood pressure. I think we need to re-evaluate our blood pressure measurement. I really do. And then also, blood pressure is not just about the absolute value. It's actually the responsiveness and the responsiveness of the end organs. Babies have a very poor responsiveness to blood pressure in terms of their ability to change their baroreceptors. So this is what a normal baby does when it's quietly asleep or quietly awake. It has these little iterations in its blood pressure. So its blood pressure goes up, and a little bit later, I think it shows it on this, yes, with a little delay, the afferents sense the blood pressure in the aortic receptors and in the carotid body, goes up to the brain, the vasomotor sensor senses that, and with a delay of about 1.92 seconds, the heart rate goes down in responsiveness. Okay? That is what's known as a spontaneous baroreceptor reflex. So you get these up and down bits with the blood pressure, and then you get a responsive change in heart rate. That's what we all do. That's one of the mechanisms that we do to maintain our blood pressure. How good is it in the neonate? Well, if you do this in an adult or a young child, you get an identity between this systolic blood pressure change and the R to R interval. But if you're sick, or if you're a preterm infant, you have that. It's much flatter. What does that mean? It means that if your blood pressure goes down because perhaps you've given some anesthesia or because you've lost a bit of volume, it means that your responsiveness has gone. And anesthesia generally dampens the whole thing anyway. So you've got a neonate that has a very poor responsiveness to its sensors in its aortic arch and its carotid body, and its responsiveness is poor. And so it actually, again, it means that we as the people who are caring for these very fragile infants need to pay a lot more attention, because the baby itself can't regulate. Its homeostasis is gone. And the sicker they are, the worse is the homeostasis. In fact, this is some data we published a few years ago looking at awake neonatal coarctations. And it just shows you that if you're a cardiac baby with a coarctation, these are looking at pressure and depressor ramps on your baroreceptors, that compared to controls, you are very damped. Okay? Now you can then say, okay, let's not look at the blood pressure itself. Let's look at the effector organs, because that might be quite useful. And I think near-infrared spectrometry, which we talked about quite a bit in the last 2 or 3 years at the APA, is a tool that probably should be used more in neonatal anesthesia and in management of the sick paediatric patient, because it gives you a bit of an idea about the effector organ. Just to give you a bit of a flavour of that, this is a study that was published in 2012 looking at that relationship between arterial blood pressure and cerebral oximetry. Now normally you have a degree of autoregulation in your brain. So an awake adult, if the blood pressure changes, there is an autoregulatory response. But this is a trace of a single child, but there were some others, looking at after ductal ligation. What it shows is that after ductal ligation and anesthesia, you become passive. So again, another example of how when the blood pressure goes down, because you haven't got the autoregulation, your cerebral perfusion goes down. You have lost your autoregulatory ability. So you've got baroreceptors that are going, you've got local organ responsiveness that is much poorer in the preterm neonate. Again, a call to arms to actually, we have to take that responsibility on for the neonate. We don't just get them through, the child's okay. We may have a surviving child at the end, but we may have knocked off a lot of extra neurons in the process. So I think we have to up our game. And this is another example of how we can use NIRS. This is looking at the ratio of the cerebral oximetry to the gut oximetry, in tissue oximetry, and showing, it's in a piglet model, that those who have a low ratio, so they've got low saturation in their gut compared to their head, are the ones that are likely to get necrotizing enterocolitis. And again, it's a monitor that maybe we need to be adopting in our practice. So what do we do about blood pressure? Well, I think first of all, we need to start to understand the thresholds of concern. I think we need to try and understand to measure the blood pressure better. I think if that means we have to go back to Dopplers and manually measuring the blood pressure to get a better number, I think that's important. We need to be tighter in our control in these very sick children. We need to compensate for the lack of autoregulation, which we know happens under anaesthesia and in a sick child. And we need to develop better monitors of organ well-being. We are not in an end stage with tissue oximetry yet. I think we've got a long way to go with that. I think there's a lot more data we need to be pulling out. And we need to learn and take note of the fact that the neonatal studies from the paediatricians are looking to 2 to 5 years. And I know our epoch of involvement is much smaller, but we should be looking at trying to work with them to see if we can optimize our practice with them in liaison. So I'm now going to turn to a little bit about oxygen and CO2, which we heard a little bit about yesterday, but this is a slightly different slant on it, and I don't apologize for going through this again, particularly those who weren't there. So hypocapnia, we all do it. We take a small baby, and when you're nervous, a bit more is better. A bit more oxygen, a bit lower CO2, a bit more ventilation. Baby's okay, our margin of safety and our comfort level goes up, but it's probably not good for the baby's brain. And chronic hyperventilation reduces the cerebral blood flow and will increase the risk of neurological damage and can affect, and has been shown to affect, their long-term neurodevelopment as measured on Bailey scores. So this is some data from 2006, and it looked at babies who have been in a preterm unit and had cumulative exposure to hypocarbia. And if you go back and look at the way we used to ventilate these babies in neonatal unit, we use pressure ventilation. So if you use pressure ventilation, you get a gas that's good, which usually means the CO2 is low, so you turn down the ventilation. And so you're always behind, always hypocapnic, because you're always playing catch up with the carbon dioxide levels. We should be playing a different game on that in neonatal intensive care now, and I'll come back to that. But the point of that, this slide, is those that had the highest time with low CO2 are the ones that ended up with the increased periventricular leukomalacia. So the amount of time, we have 4-hour operations sometimes in neonates. Should we be paying more attention to the CO2? Yes, I think so. I think we need to be doing that. And the changes are really quick. So this is just a study from one of our patients, just that we were looking at the cerebral tissue oxygenation, and we looked at changing from 30 to a condition when he had 40 millimeters of mercury and back, and you can see that the cerebral oxygenation changes really quickly, just with very small changes in the carbon dioxide tension from ventilation. So it is exquisitely sensitive, and things that have changed my practice. I'm now very careful, because if you have a cerebral oxygenation monitor on, you suddenly realize what the damage you're doing by hyperventilating these patients. So your first blood gas comes back and the CO2 is 27, and you see this on your knees. Not good. So the name of the game, I think, is trying to look at pressure regulated volume control in the operating room in these small babies. As I said, we are so used to pressure ventilation. I know Xavier talked about volume ventilation, but a lot of the time we actually are pressure ventilating, because we look at the pressure and we think, well, that pressure's okay and that's okay. And pressure ventilating is not smart ventilation. This is smart ventilation, because you're using a ventilatory system that measures the volume and the pressure, and you have a smart ventilator that adjusts the pressure to give you just the tidal volume that you need. And if you think, from your old physiology, that your CO2 is inversely proportional to your CO2, what that means is if you can fix the tidal volume, you're relatively fixing the carbon dioxide level. Whereas when you're pressure ventilating, you are compliance dependent, always compliance dependent. So volume control is better for controlling the CO2 and clamping it, but you've got to have a smart ventilator to prevent yourself from overpressurizing the patient. And that's essentially what these guys do in modern PRVC or volume control. So you have a working pressure, you're trying to achieve this volume all the time, and it adjusts the pressure to try and each time iterate itself to the ideal or optimized tidal volume. So in the last 5-10 minutes, I'm just going to talk a little about oxygen now. We'll move on to oxygen. So oxygen, we now know, and Wally talked about quite a bit. Certainly long-term, high oxygen is bad for you. So the question we're all asking is, okay, is that important in anaesthesia? Exposures, when we want to put a tube down, is it important that they give 2 or 3 minutes of high oxygen? Is that important or not? And I would argue that it may well be important. So now I'm just going to point to this one study which I think points that way. This is the Vento study. Looked at 78 neonates, less than 28 weeks gestation, so small babies. And they resuscitated with either 90% oxygen or 30% oxygen as your starting point. However, it wasn't just blindly you had 90% oxygen or 30% oxygen. They changed their FiO2 as the resuscitation progressed. So as soon as you got control, down went the oxygen. So the exposure to high oxygen was really quite short. And he looked at the outcomes of these two different treatments in terms of oxidative stress, inflammation, lung performance, and evidence of BPD at 36 weeks. Now this is the crucial thing. This is where I think as anaesthetists we have to grab this. So remember, 90% oxygen versus 30% oxygen. There's the low oxygen, there's the high oxygen group. The exposure was less than 5 minutes to the high or low oxygen group. Not very much. And after that, because this is the way the method was designed, you were trying to get the SpO2 the same, and so you could come down on the oxygen as soon as you got where you want. So only less than 5 minutes. However, once you start looking at the inflammatory things, and this is days later, 15 days later, IL-8 levels in the group that had the high oxygen were significantly raised. And IL-8 is very much associated with lung damage in these guys. So you are increasing what they call the inflammatory load on these guys simply by 5 minutes of oxygen. Nothing else changed. It was otherwise a completely controlled experiment. And the same is, there isn't time to talk about these, but they looked at DNA markers, protein markers, lipid markers, oxygen stress. All the different markers of oxygen stress are raised in these groups. So the outcomes, it wasn't so much an outcome study, it was a biochemical study, but the outcomes are likely to be somewhat worse. And certainly in terms of BPD, those who had even short exposures to the higher oxygen had a bigger inflammatory load, and their lungs were not so good, and they were oxygen dependent for longer at the end of the study. So to finish with, there are the 4 cardinal rules of anaesthesia. You need to make sure the patient is asleep when they should be and wake up when they should be. Nobody's going to like you if you don't give good analgesia, so pain relief is important. There is no substitute for a live patient. I haven't found one yet. But the other thing is more important is look cool, be quick and slick. That's 4 cardinal rules. But I think there's a 5th one, is to think beyond the horizon. Think outside the 4 walls of the operating theatre, and actually I think we need to up our game. Thank you very much. So if we got time, I just wonder if we could take a few questions, if I could invite the 2 speakers up just even for 5 minutes, and then we'll stop and then we'll hang around for a bit so people want to come and talk. Peter.
I'm Peter Kempthorne from Christchurch, New Zealand. It seems to me that the discussion about ventilation from Javier was, I can sort of start to hear the high frequency oscillatory ventilation thinking coming in, where you're setting a distending pressure and overlaying on that a clearance of CO2 amplitude, but we haven't seemed to discuss frequency at all. Do you think these 2 ventilations are starting to sneak together?
Yeah, you hear me, no? Or maybe I can use this one. Yeah, I didn't have time, but when I speak specifically about recruitment maneuvers and open lung approach in pediatrics, we have to talk about high frequency. Oscillatory high frequency ventilation nowadays is the gold standard for preterm babies, neonatal babies. All the studies about recruitment maneuvers as done with high frequency oscillatory ventilation. Clearly, if you think about it, in my opinion, is very nice, because at the end, in a blinded way, because pediatrics usually is like why always use pressure? If you ask them, why you always use pressure in neonates? They don't give you the answer, but they use it. So high frequency auditory ventilation at the end is a huge amount of CPAP or PEEP with a very tiny small tidal volume, less than dead space, 2-3 milliliters per kilo. So if you put this in context, what you're doing is to recruit the lungs with a huge amount of PEEP of CPAP. After that, you reduce the tidal volume, the cyclic stressing process as low as possible. So high frequency auditory ventilation at the end is to put all the concept of protective ventilation up to the maximum point in a blinded, in my opinion, in a blinded way. But it's exactly the same.
Yeah, that's true for ICU and for anesthesia. There are two ways of thinking. As was mentioned before, we have to be very much aware of the IE ratio. The IE ratio, when looking at it, why do we use pressure controlled, in fact? It's because the decelerating flow will allow the same ventilation with lower inspiratory pressure. This is why the pressure control is essential in pediatrics. And this is why PRVC is also very attractive, because it does use the same decelerating flow. And therefore, but it guarantees the volume, tidal volume. So this is very important. But in the two modes of ventilation, the idea of the ventilation parameters you're doing, you have to think time constant, which is the product compliance versus resistance. And therefore, taking into account the time constant of your respiratory system, you are obliged to decrease the respiratory rate to allow enough time for the inspiratory time, or to allow a good IE ratio, to have a good homogeneity or equilibrium in your ventilation between the alveoli and the trachea. Now, this is to go for the frequency, and we tend to over-ventilate the children and not looking at this flow time curve on the ventilator that will give you an insight on what's the time constant. So this is very important. The second point I want to get to it. High-frequency ventilation is now somehow a new technique of controlled rapid sequence ventilation. Let me detail this. It has been published first by the team from Zurich of doing, keeping the FRC and expiratory lung volume during rapid sequence ventilation by maintaining a CPAP. In fact, either you do a very slight ventilation, or when you do rapid sequence ventilation, what we call controlled rapid sequence ventilation, you can do manually with your circle or with the Jackson-Rees modified whatever accessory circuit, your high frequency oscillation, which is similar, exactly what is the ICU, is to keep the restore or keep the FRC at the optimal level to maintain gas exchange, the time of getting the myorelaxant acting before intubating. Is it okay? Does it answer?
Can I just play devil's advocate with these two at the same time? Which is okay, outcome data. So since Alison Freese's early papers in the 80s on the oscillator, in the sickest patients, oscillators have not shown yet to have any outcome benefit. I'll just throw that into the equation.
You're right. You are completely right. And the two meta-analyses didn't show anything. The only thing which is interesting in the high-frequency oscillation, actually, when you compare to conventional ventilation, is the changes in the venous cerebral blood flow. Right? Yes. So we don't have, I don't have any other argument. You know what I mean? Yes. It's only physiological effect of your mode of ventilation. But you are completely right. There is no difference on outcome or incidence of bronchopulmonary dysplasia, etc. But then let's have a look on the other compartments. I don't know.
To add just one thing, in the world of neonatologists, they are not used to conventional ventilation, recruit maneuvers, protective ventilation. If you put all the pieces together, oscillatory ventilation, the problem is how do you monitorize tidal volume? You cannot monitorize anything. How do you know if your patient is overdistended? You cannot control that. So at the end, if you apply all this protective concept that at the end is to keep it open and don't let collapse the lungs again, you can do it with conventional ventilation at the same time. Normal.
I wish I'd had you guys in my exam. You could have just talked amongst each other and I could have kept quiet. Can I just ask one very quick point? Lecturing to us is great. We are applied physiologists.
I don't hear you, sorry.
Sorry, okay. Lecturing to us is great. We are applied physiologists. This is what we do.
Yeah.
The problem is...
But I think better with the microphone, no?
Well, I don't know. Okay. Is that better? Fine. Yeah. The problem is, I'm used to being an applied physiologist. I'm quite happy to look at a patient being ventilated for 8 hours and then press a button thinking, I wonder what this does, because that's what we do. How do we convince our friends and colleagues, the neonatologists, away from the inspiratory time of 0.25 and the rate of 60 with no PEEP? This is the real problem. There's no point in us being exquisitely careful in theatre if I then go back, set the patient up very carefully, walk off, and it's all been changed 10 minutes later.
The only thing I can tell you is I can share something with you, always through visual things. I perfectly still remember in the big hospital, old lady that really don't want to make recruit maneuvers in neonates, especially neonates and preterm baby, because there's always a fear about to create pneumothorax. And I say, okay, don't worry, I'll take a video. I'm going to record what you are doing with the TPs. You make the anesthesia. You are with a manometer. So I connect a manometer, I am going to record the manometer, and you make the anesthesia as you used to do it. When we find all the cases, I show the record to her. Sometimes with the black bag, you know how much is the maximum pressure you can reach with this bag? More than 60. So, of course, to change the mentality of our colleagues is quite complicated. The way of doing that is with visual, simple things. But, and I fully agree with you that in the future, we will see the results when everybody changes our mentality. So, really, the difference in protective ventilation comes when you treat the patient before coming to the anesthesia, in the induction period, inside the operating room, and in the post-operatory period. If you only try to take care of one part of the puzzle, you'll never see the difference.
I wanted to ask Walid, under what conditions were you ventilating your patients when you were making the I to E ratio changes? Was it PRVC?
Yes. Each time you think about decelerating flow, you have to think about time constant. So each mode of ventilation with decelerating flow, which is pressure control, pressure regulated volume control, then you have to think about IE ratio.
So what you're effectively doing is you're changing the mean airways pressure of each breath, right?
Well, now let's take it differently. When you have a neonate, for instance, a neonate, the inspiratory time is between 0.4 to 0.6 physiologically. So this is the first way where you starting, you start putting at least a limit. The more you increase your inspiratory time, you improve your ventilation somehow. But you jeopardize your hemodynamics, so you have to be careful somehow. That's why you have to monitor your flow time ratio. So it's useless to just put the respiratory rate 40 or 45 because it's a neonate. It doesn't make anything. You have to adapt with regard to the IE ratio with the flow time, and then to think about the time constant, and then you might ventilate with 32 or probably with 44. I don't know. As soon as you have a IE ratio which allows a good equilibrium, because as it has been said before, just by adapting your IE ratio, you will decrease your inspiratory time, you will decrease your driving pressure. So in fact, this is how you adapt it. Does it answer your question?
Yes, thank you.
May I say something about that? Because people are going to think that this question was prepared, because I really have a case with volume, very controlled, regulated pressure. As you can see here, value is
You see here, this is the flow time, right? You can see this is the flow decelerating, that it is interrupted. In fact, your IE ratio is wrong because it's not coming to zero. So what does it mean when it comes to zero? You have an equilibrium between your alveoli pressure and your trachea pressure. So you need to get this to zero. You need to get the expiratory time to zero. This is not good, so we have another one. So this is typically a bad ventilation. You don't have any equilibrium, and the only way to get to a good gas exchange, you're gonna increase your pressure, which is not the case, because if you allow enough IE ratio, and to do it like this, you have to decrease your respiratory rate, and then all of a sudden, you will see that you will improve your tidal volume, and then all of a sudden, you have to decrease your respiratory pressure, and then you have a lower driving pressure.
It's like that. Everybody's thinking like everything was prepared, but it's what Vali said. This is a normal case after 1 day of cardiac surgery. Check the ventilator every single day. As you can see here, the driving pressure is 23 less 5 is 18. Just changing the rate, as Vali said. The only thing you have to do is to go to the second screen and change the expiratory time, see what's happened. You reduce the pressure in 6 points, no? So it's now 12. Sorry, no, 12. From 18 to 12. The other way of ventilating is creating damage, and this is absolutely safe. Even more, if you make a recruit maneuver and you let the patient in volume control regulated, see what's happening. This is a recruit maneuver. We adapt the inspiratory time and see what's happening at the end. Only with 2 more points of PEEP. At the beginning was 5, now it's 5. 15 less 7, only 8 of driving pressure. And it was 18. 3 minutes later, just with the physiological programming, we reduced driving pressure by 10 points.
Can I just mention something? Most specific neonatal ventilators, you have on the setting surface inspiration time and not an I/E ratio, because the I/E ratio, as long as you have enough time for the expiration, doesn't matter at all. The absolute inspiration time specific for the time constant of the baby is the relevant thing. And this was found out in neonatology already 30 years ago when I did neonatology. Okay.
I agree with you. The only who really take care of this as pediatric anesthesiologists. But only one thing, to push in both sides. Pediatrics never use this programmation tool because they put a fixed inspiratory time, and they change the other one. They don't touch it. So, yeah. But it's clearly that this is very useful, especially for in pediatrics area.
We'll take one more question. If there's one more question, and then I think we'll draw the meeting to a close.
Hi. My concern about increasing the PEEP is the intrathoracic pressure and the side effect of high intrathoracic pressure. Is this concern realistic in your experience or not?
Yeah, I'm gonna show you. I'm sorry, I have. Give me 2 minutes, because I have also the slide.
Xavier, you go first, and then you put another slide on.
Yeah, I can go. In the meantime.
We'll just move into another lecture. That's good.
Okay, go. This is the about. No problem. Don't worry. Both.
Boys, don't squabble.
No problem. Both of us is going to say the same. What is really the concept about PEEP? What is really important? About hemodynamic repercussion is to set the minimum you need to keep the lungs open. It's a concept, but it's very, very important. If you need, for example, 10 of PEEP to keep the whole lungs open, I'm going to, when I reopen the lungs, I'm going to reduce pulmonary resistance because you are inhibit pulmonary vasoconstriction. So you are not going to even have more hemodynamic impairment. You are going to improve the hemodynamics, because the right side of the heart is going to, work much easier with less pulmonary resistance. The problem is every single point of PEEP that you set more than these lungs need, then is when you find overdistension, and then is when you find hemodynamic repercussion. And it's a clear case. Neonate. A normal neonate needs 3 of PEEP. If you set 5 or you set 10, you are giving to him 7 more than they need. And this is going to give you, or is going to create hemodynamic impairment. But if you set 0 of PEEP, you are going to create atelectasis, and the heart have to work in much worse condition, because you are going to have pulmonary hypertension.
Okay, I want you to focus on these 3 curves. I didn't explain that to you because I didn't have time. The blue one is the one with 3 peak. The green one is the one with 9 peak. And these rabbits were ventilated with 6 to 7 mL per kilo. And the red one is the rabbit ventilated with 12 mL per kilo. And look what happens. The peak has no effect on the blood volume in the lung. And the large tidal volume, you put an inspiration, you decrease completely your hemodynamic. So just to tell you that it's not the peak that will jeopardize your venous return, it decreases the blood volume in the lung. And this is visualized completely on the iodine perfusion in the lung. It's more the large tidal volume you are using, right? So if I don't know if it answers your question, this is why I wanted to show you this slide.
So I'm going to draw this symposium to a close. Thank you everyone for coming. I really thank you to the speakers. I think it was a really good, and also thanks to Mackay for making this happen. So great thanks to you. Okay, thank you, Xavier. That was great.
Really, it's a pleasure to meet you.